All right, here's our introductory comment. Neuroendocrine tumors today. Welcome, everyone. And if we have questions as we go along, please feel free to write them into the chat. It was suggested we talk about neuroendocrine tumors. And I'll also activate the captions. So that you can read my words as well. And this has been a very interesting topic to prepare. So just briefly, what are these tumors derived from? Generally, we consider them to be originating from neuroendocrine cells that are embryologically derived from the neural crest, and therefore they share certain morphology, certain immunohistochemical features, and they can present in a variety of locations. Most commonly, this is in epithelial or tubular organs, but we really see them everywhere from essentially the head to the tail, more or less. We don't see them in the extremities to any great degree. And these cells contain neurosecretory granules that are usually detectable by immunohistochemistry. It's also interesting to think about their function. So some of them have a very local signaling or regulatory function, their local region, while others have a systemic impact, like insulin and glucagon and so forth. So it's a very multipotent local versus long-range capability that these cells have. So the tumors that are derived from this primarily, most commonly, are very well differentiated. And so these are tumors that these well-differentiated tumors, we recognize by their nuclear morphology, usually very round, sometimes round cells, round nucleus, low grade, low mitotic rate, varying kinds of architecture with trabeculae or island-like patterns, sometimes spindle-shaped cells, and very low proliferation rates and so forth. So I thought we'd first start and look at the lung, and this is a very interesting case that I found online from the University of Leeds, and see several small tumor nests here in multiple sections in this wedge biopsy from the lung. And this is just one of these lesions. We might call it a tumorlet, or even be thinking about other possibilities. There's a little distortion in their scans, but you can see that there are very round, quite uniform nuclei, a moderate amount of cytoplasm, and so forth. And when we see multiple nests like this that are varying size and shape, some within the parenchyma and out into the lung parenchyma of this sort, this is a characteristic of an entity called diffuse pulmonary neuroendocrine hyperplasia. And as such, it is somewhat of an unusual phenomenon to get this in the diffuse manner. And we might think about other possibilities, but that is what we would want to see. If we have just one of these, we would call it a tumorlet. If we have multiples, we will call it the diffuse neuroendocrine hyperplasia. When one of these becomes dominant, size greater than a few millimeters, it would be a carcinoid tumor in the lung or a well-differentiated neuroendocrine tumor. Now, we probably see something like this also in the pancreas, nocidioblastosis and so forth in the pancreas. But I thought it would be interesting to see this diffuse neuroendocrine hyperplasia in the lung. Our typical well-differentiated neuroendocrine tumor in the GI tract looks something like this. So you see this polypoid tumor. It involves the mucosa. It penetrates through the wall. And here again, we see this nested pattern architecture that we characteristically recognize as a well-differentiated neuroendocrine tumor. And this is not a diagnostic challenge. It does become a management challenge because behavior on these lesions can be quite variable in the small bowel with recurrences, metastases, and so forth. Now, sometimes, particularly in the small bowel like this, these tumors are occult, and we may not recognize them. And in fact, today I had a case which presented as a metastatic lesion. And the story was somewhat unusual. It's going to take a minute for this to load here. Let's see if we can well, we'll come back to that. I'll reconnect here. Forgot about that. So the story was the patient had a history of breast cancer and had been treated, and this was triple positive breast cancer, ER positive, PR positive. So that was somewhat concerning when she presented with what appeared to be a liver mass when she was seen and evaluated on follow-up. So let's see if we can get in here now. Open the gateway. Let's see. So she presented with a lesion in the liver, and we'll get there. Patience. There it is. And here you see what the liver biopsy looked like. So this is another important lesson, I think, on neuroendocrine tumors, is that the metastatic lesions can mimic other tumors. So here we see a nested pattern of metastases, tumor cells, areas of necrosis. So this, I thought initially, could be compatible with breast cancer. And so I just did a few markers initially to verify that it would be breast cancer. And lo and behold, it's ER negative, it's PR negative, it's HER2 negative. And that seemed a little bit unusual to me. And it was also GATA3 negative. So I did a second round of staining, and lo and behold, it did show some positivity here with, this is the right thing. No, that's not the right one. It was negative for liver markers. Here we go. Nicely positive with synaptophysin and with CD56, as you can see here. So we made the diagnosis of a neuroendocrine lesion. Now, this lesion also showed positive reactivity with this next marker, which is TTF1. So I ask you, does that mean that this is a metastatic neuroendocrine tumor from the lung? Anyone want to answer? So no, we have learned that a number of these homeobox markers like TTF1, PAX8, sometimes CDX2, these nuclear markers can be sporadically positive in tumors without necessarily implying that the primary tumor originated from what we typically associate with the epithelial tumors that mark with this marker. So that was another little teaching point to bring back on these lesions. And it may very well have originated with a tumor just such as this, maybe a cult in the small bowel or somewhere else that has metastasized to the liver. Now, I've included a couple of other tumors here, at sites where we can see this very commonly. The appendix, as you can see here, typically the distal appendix. That's why we do longitudinal sections of the distal appendix, so that we can identify these tumors. Because metastasis is very difficult, so identifying them and we can follow up appropriately over time is valuable. Let's see, we got one more here. Here's one from the stomach. And in the stomach, these tumors, of course, may be associated very frequently with the achlorhydria sort of situation in patients with atrophic gastritis, where the neuroendocrine cells are experiencing a lot of drive to produce gastrin and raise the pH in the stomach. And so the neuroendocrine cells become hyperplastic. But if this is the case without that atrophic gastritis, and where you just have a nice pattern, again, nested, abundant cytoplasm, very uniform cells, and the characteristic salt and pepper nuclear features. And let's see, there's one other, I guess, here. I believe this is also from the bowel, just to illustrate another pattern, which is sort of this insular and almost trabecular pattern. This one has some as well, however, because it shows this rather than central nuclei, we see here peripheral nuclei with maybe some clear cell change or granularity to the cytoplasm, sort of mimicking a pattern. And these pseudoglandular changes can also be quite deceptive and lead us to think about adenocarcinoma in the differential as well. So our threshold to order stains to look for the neuroendocrine differentiation should oftentimes be fairly low. Now, this is a tumor from the pancreas, and it shows another feature that we can associate with particular tumors in the pancreas that are neuroendocrine tumors, and most commonly are producing insulin. And that is this very hyaline fibrosis or production of actually amyloid. This is an insulinoma, which is producing amyloid and arising from the pancreas. So that's fairly specific to insulinomas in the pancreas, and is a useful marker. Now, of course, not all hyaline fibrosis is amyloid, but when you begin to see it in a pattern like this, with sort of massive or ropey-like deposits, it's pretty solid evidence that that's what it's going to be. We've seen metastases in the liver. Here's just an example of lymph nodes. And this is a lesion which you have to be a little bit careful of, because as you can see, it's a fairly blue tumor, and if it totally replaces the tumor or the node, you may just see a mass of tumor cells. And if you're not looking at higher magnification to identify the characteristic morphology, you might just pass over and say it's just a lymph node. So these lesions can, because they're small cells about the size of lymphocytes, they can be a little bit deceptive in terms of identification as lymph node metastases, whether they're in the subcapsular sinus or within the body and parenchyma of the lesion. Here's another example, again, where I think you might, low magnification, just say, oh, this looks like a lymph node, next case, because it's very blue and has a little bit of this sort of, almost a sinusoidal type of architecture. And this case is not very well fixed. So even when you come to look at this at higher magnification, you may just think these could be lymphocytes or plasma cells or histiocytes or something like that. And because it's not well fixed and a little bit discohesive, this has a metastatic lesion, unless you're very keen to identify in the better fixed areas, maybe towards the periphery here, then you have this nice little degree of packing these cells, and they're sort of nesting up here. Also, there's a little bit more atypia here in this regard. So one thing with regard to grading, as you know, we grade tumors in the well-differentiated neuroendocrine tumors on the basis of mitotic index and Ki-67 labeling index. The mitotic index is greater than 2 mitoses per 2 millimeters squared, puts you into the grade 2 category, and greater than 3% Ki-67 labeling index puts you into the grade 2 category. Either or of those is enough to make it a grade 2. And so an awful lot of tumors will actually be grade 2 if you are doing rigorous Ki-67 500 cell counts of that lesion. So here's the cutoffs: less than 2 mitoses per 2 millimeters squared, or a Ki-67 index under 3%. When we're between 2 and 20 or 3 to 20, we're in that grade 2 category. And so any higher lesion falls into this grade 3 category. But if we are thinking we're in this category, we really need to be very careful to make sure that it shouldn't be just classified as poorly differentiated neuroendocrine carcinoma. In other words, is the cytologic atypia and so forth sufficient to, and things like necrosis and so forth, sufficient to move it into that category where it has a higher risk of metastasis, and we're going to call it carcinoma. Now, importantly, we don't find hormonal syndromes associated with these tumors in the majority of cases. It's sometimes 10, maybe 10 to 30% is the category. But this is not particularly important because these are usually recognized clinically, and the immunohistochemistry does not necessarily correlate with secretion. So doing immunohistochemistry for insulin or gastrin or whatever is not particularly worthwhile because it does not correspond to the clinical scenario very often. So in the pancreas, I mentioned insulinoma. Here's another example of a tumor in the pancreas, just to give a spectrum of the morphologies. Here again, I think this is probably an insulinoma. You can see this nice hyaline, very amorphous pink material here, as well as some fibrillar collagen. And notice here that some of these tumor cells have or begin to have a spindle cell morphology, which is another feature that we can identify in the tumors. These look different from the surrounding islets in the surrounding pancreas as well. Here, another tumor in the pancreas. Again, a slightly paler morphology. And here you can see some intervening fibrous tissue, but epithelioid appearing cells, fairly abundant cytoplasm. Now notice here that we begin to get a degree of nuclear pleomorphism. And in general, of course, nuclear pleomorphism in neuroendocrine tumors, when it's in this moderate range, does not correspond to malignancy per se. So you don't need to consider this as a marker of carcinoma just on the basis of nuclear pleomorphism or atypia. When the cytologic atypia becomes sufficient that you have a difficult time recognizing it as a neuroendocrine tumor, that's when you're more likely and better off to call it carcinoma. So neuroendocrine carcinoma we define as diffuse sheets and nests with marked cytologic atypia. You begin to lose the nuclear features of salt and pepper chromatin, many more mitoses and apoptotic bodies with necrosis. In the pancreas, these tumors tend to lose the RB1 marker if you have that available. We occasionally order that as a send out. They'll also have SMAD4 or DPC4 loss as well. I've never used that marker. And they tend to be much more likely to have an abnormal phenotype for P53. So in other words, they tend to be P53 mutated in some format or another, which may be useful to you in some cases. So here's a couple of examples. Here's one. I believe this is from the pancreas. We can see here that it still has kind of the architecture of a neuroendocrine tumor. So it's got a trabecular, anastomosing, and tubular pattern. But notice here that the nuclei are much larger. There's more crowding. There's more pleomorphism. There are quite a few mitotic figures and certainly some apoptotic bodies here in this lesion. So differentiating this from grade 3 neuroendocrine, well-differentiated neuroendocrine tumor versus neuroendocrine carcinoma. The person who gave me this case said they felt that it fit better with neuroendocrine carcinoma. And in most cases, neuroendocrine carcinoma has some remaining nuclear features, molding and so forth, of neuroendocrine carcinoma, and it's not defined purely on the basis of immunohistochemistry. So it has some morphologic features of a neuroendocrine tumor, but is clearly more pleomorphic, more mitotically active, and so forth. I think there would be some observers who would call this a grade 3, assuming that the proliferation indices are high enough. Here's another example, and I apologize here for this. This is from the ampulla, and as you can see here, we've got some small amount of mucosa wall, but here notice we've lost more of that architecture, and as we come into higher magnification here, there's really not much going in the way of cohesiveness here. These are very large nuclei, a lot of mitotic activity, and so this was called small cell carcinoma, neuroendocrine carcinoma of the ampulla monitor. And of course, these will still stain neuroendocrine markers. One last example here. This one with a tremendous amount of necrosis. Looks much more like just pure small cell carcinoma, but arising in the pancreas in this manner, what's called neuroendocrine carcinoma, or small cell carcinoma of neuroendocrine type. So this looks purely like a small cell carcinoma in this setting. Well, what are some of the other lesions that can come into play here, and some of the other locations? Well, so one of the other locations we can see these tumors is in the GYN tract, for example. And so before I come back to, I'm going to go to this other case here, which is a seminar case from Dr. Rosai's collection, in a patient who had an ovarian mass. And in this particular case, the majority of the mass was characterized by what we see here. Hopefully this will come into. Let's see if I can read. Oh no, here we go. It's coming into focus. So you see here a nice squamous epithelial lining with keratinization. So in the ovary, this was a mature cystic teratoma. Except that in the wall, it had this lesion here. And as you can see, eventually it'll come into focus. It has the nice trabecular pattern of neuroendocrine with characteristic features of a neuroendocrine tumor. So this is a carcinoid or neuroendocrine tumor arising in or in association with a mature cystic teratoma. Now, of course, we know there are monitorable teratomas that are pure carcinoid that occur in the ovary, as well as the struma carcinoid tumors that occur in the ovary as well. So the GYN tract is not immune. And in fact, that brings me back to our case here, because this case was a uterine tumor. So we had nice positive staining with neuroendocrine markers in a small cell malignancy. So curating from the uterus, small cell carcinoma, a neuroendocrine carcinoma arising in the uterus. Now, interestingly, so this was the Ki-67, which was markedly elevated as well. There are also cases where we get a mixture of neuroendocrine and non-neuroendocrine tumors. This has an arbitrary cutoff of at least 30%. And usually this is a poorly differentiated neuroendocrine carcinoma with varying types of adenocarcinoma. But other cancer types, squamous, et cetera, can also be seen. And rarely you'll have a well-differentiated neuroendocrine tumor along with an adenocarcinoma or other tumor. I suppose you could even think of these mature teratomas as a type of mixed neuroendocrine tumor, non-neuroendocrine tumor as well. Immunohistochemistry can be useful, and usually here it's the higher grade tumor that determines prognosis. The problem with this 30% cutoff is, what do you do when you're dealing with a biopsy? So to illustrate that, I picked a case that was a mass in the esophagus. And here we have 4 or 5 fragments. We can see a lot of very blue tumor here. And we looked at this and said, oh, this is small cell carcinoma. Maybe this is metastatic from the lung or primary here in the esophagus. We have nuclear molding. We have lots of high-grade malignancy, high-grade morphology, and so forth. And I was just about ready to sign it out as, small cell neuroendocrine type carcinoma when I noticed it's one little fragment off to the edge here. Here we got a little bit of squamous mucosa and so forth. And then the endoscopist gave me this one additional piece that looked like granulation tissue, partly, except that, whoops, here we have what looked like clearly malignant glandular fragments. Now, this is probably not 30% of the tumor in the sense that I can compare, the morphology of this part with the other pieces that I have in this slide, which are, 4 or 5 pieces of tumor that are, multi-tumor. So I still sign it out as potentially mixed neuroendocrine, non-neuroendocrine carcinoma. And interestingly, in this case, here are the synaptophysin markers, and as you can see down here, these glandular elements are also marking with some of the neuroendocrine markers. Well, actually, this is a nuclear stain, so I believe this is not a synaptophysin or anything like that. So this is probably a P53 or a TTF1 or something of that sort that we marked this with. Let's see if I can tell what this stain was. This is K67, this is not K67. So anyway, that's one of the caveats that when you see it, I think you should raise the possibility. All right, well, let's talk about some of the other neuroendocrine lesions or neuroendocrine tumors that we can encounter. And one of the principal ones is paraganglioma. This is a tumor that's usually seen in the adrenal medulla, Pheochromocytoma, et cetera, or other sites of paraganglial tissue, ranging from the head and neck down to the thorax, abdomen, and so forth. Now, these very often can be bilateral or at least even multicentric and have the capability for metastatic disease. But interestingly, a large portion of these are associated with heritable syndromes, whether that's multiple endocrine neoplasia or neurofibromatosis or other syndromes. And so when we encounter one of these patients probably should undergo genetic testing. Now, most of the ones that occur in the head and neck are involving parasympathetic ganglia, whereas in the thorax and abdomen, they're the sympathetic ganglia that are involved. Gangliocytic paraganglioma is kind of a special case, which is a sort of a composite ganglioneuroma and neuroendocrine tumor, which I unfortunately could not find a good marker for, or a good example of. Now, clinically, these often have elevated metanephrines or catecholamines, particularly the adrenal ones, and we don't. They may not even need a biopsy to make that diagnosis in this setting with the appropriate mass and symptoms. But if you do need to do markers, obviously the neuroendocrine markers that we've discussed already will be positive, as well as INSM1, which is a newer marker for neuroendocrine differentiation. And in the paraganglial lesions, the sustentacular cells will be positive with GFAP and SOX10, as well as X100, although that can be positive in both components. So here's some nice examples of this lesion. Here's a carotid body tumor, as you can see here, nice muscular artery. And in our setting, not infrequently, the radiologists will try to be helpful and minimize the vasculature to these lesions by embolizing them, which is what they've done here with some sort of thrombotic material which is present in the tumor. As we can see, the characteristic sort of balls of cells, or cell ball, as the German pathologists initially named them or describe them, with a very rich vascular backdrop, which of course makes for great access for the hormonal products and great challenges if you're trying to remove them surgically. So there's quite a body tumor. Here's another head and neck lesion with this carotid area. Again, we see a quite vascular background. And here we can see again this degree of nuclear pleomorphism and atypia that in these lesions has no relationship to malignancy and so forth. And notice also that the cytoplasm here is quite amphiphilic and granular. So if I had given you this picture and said this is adrenal, you might have very easily jumped to think, Pheochromocytoma, while paragangliomas, other places can have that same appearance. Now, sometimes because of the hormones involved, these will actually be very black. You may have the carcinoma converted to melanin or other black marking pigments. Here's another example. And I'll give you the link to these so that you can come back and spend more time with these lesions if you'd like to afterwards. This lesion, not quite as vascular and more sclerosis, but you can see there's a lot of red cells in between here. And again, very balled up type of appearance, rounded cells and rounded cell nests. And here we begin to see some of this pigmentation that can be associated with these. So the so-called black adenomas in the adrenal and elsewhere can be related to this lesion. Of course, black adenomas can also be derived as well. So here's one from the adrenal, and as we see here, I like to look at the periphery of these lesions to identify residual areas of adrenal cortex that have been compressed, and you can see maybe just a little bit of that here in a few areas. Well, it's not showing up very well. But again, the typical morphology, very vascular network, rounded nests, and you may not always see the sustentacular cells very clearly. So if you don't see them in every cell nest, that's certainly understandable. Because sometimes these paraganglial cells will predominate. So specifically with regard to pheochromocytoma, there are a number of ways of kind of looking at this in terms of treatment and grading and so forth. And I've just included one setting here from the North American Neuroendocrine Tumor Society to mark potentially aggressive lesions. So these lesions that have a larger tumor size or have vessel invasion grossly, or if there is a known germline SDH mutation, then those are the ones that are considered more aggressive. Once we've examined it, if there's a high mitotic index or they have continued elevation of metadephrins, then those things portend bad outcomes. So here's another adrenal example. I notice this one has this kind of coursing spindle state cells, a bit of polymorphism, as you can see. And again, this amphiphilic or purple granular cytoplasm. And these can be quite atypical. Here's the big meganuclear intranuclear inclusion in this particular cell here. Here's one where you see the normal adrenal for contrast here. So normal adrenal medulla here, and tumor adrenal medulla here. Not as much packaging. And so in this case, you might even wonder, well, is this a cortical or is this a medullary lesion? And so stains can be useful in that setting to differentiate cortical versus medullary origin. Of course, the clinical scenario will also be somewhat distinct. I can remember the history here. Oh, yes, here's another. Okay, yeah, so we've got adrenal and another intramedullary example with the adrenal cortex out here and a medullary tumor here. So I won't go any further to that at this point. But as you can see, there's a fair range of morphologies that can fit into this category of Pheochromocytoma, ranging from quite nicely packaged spindle-shaped cells. Here, almost a pseudosarcomatous pattern, very frequent mitoses, maybe typical mitoses. And so you might wonder about, metastatic tumors in this setting. It doesn't have the vascularity to the same degree that we saw in some of the earlier examples. And it's important to appreciate the spectrum of disease in these lesions. And that's part of my purpose in showing you multiple examples is to help with that, because when you encounter a lesion in an area like this, if you've only seen one or two examples, you may miss the new variant or a different variant than what you'd seen and may make a diagnostic error. Whereas if you've seen some more of the broad spectrum of disease and morphologies that can be encountered here, it'll be more comfortable for you to recognize that a new case fits into this category. So another category of neuroendocrine tumor that's somewhat special and unique are the medullary carcinomas of the thyroid. These are derived from the C cells, or previously termed parafollicular cells, which secrete calcitonin. So not a neuroepinephrine and so forth. But these tumors in the thyroid are really potentially very deceptive. This has been called the great mimic, because really these medullary carcinomas can resemble many, if not almost every other type of thyroid cancer, from papillary cancer to follicular to poorly differentiated to almost undifferentiated. And it's also important to recognize that because these are often familial, that discovering one of these should lead to further investigation of the family to evaluate for the presence of other individuals in the family with the elevated calcitonin and potentially other endocrine or other neoplasms. In either case, whether it's von Hippel-Lindau or multiple endocrine neoplasia, it's usually due to a gain of function of the RET gene. And that activates the MASH pathway and so forth. So here's a nice example with surrounding thyroid, and we see this somewhat bluish tumor with some of the cytologic atypia we see here. So this looks a little bit like the paraganglial tissues that we looked at to begin with. We see some nesting, some spindle-shaped cells, and so forth. But you can see how a small biopsy, this might be confused for melanoma. Here we've got intranuclear inclusions or poorly differentiated carcinoma as well, because some of the nuclear features can mimic those of papillary carcinoma. We don't have particularly a follicular pattern of differentiation, but they can certainly be quite deceptive. I've got a couple more examples here. Nope. All right, well, let's just sort of finish up with a couple of the neuroendocrine type tumors that occur in the GYN tract. I've mentioned the ovary and showed you the case of a neuroendocrine tumor arising in a teratoma. But there's also small cell carcinoma of pulmonary type. And I've got another video, I think I've talked about that in it as well. Small cell carcinoma of hypercalcemic type is not does not fall into this neuroendocrine tumor category, has a whole different morphology and whole different molecular genetics and so forth. And then we also have tumors in the endometrium and in the cervix, where typically these are small cell carcinomas with neuroendocrine differentiation. In the cervix, these are oftentimes HPV associated, and they may be either pure small cell carcinoma or not infrequently, they can be mixed with adenocarcinoma or maybe even mixed with squamous and adenocarcinoma at times. So this is a particular challenge. And this is probably related to the HPV types that are prevalent in your area. I know we've seen a few more of these from the Southeast Asian domain than we see in our native population here in the United States. So I'll just show you a couple of examples of this. Here is, as you can see, a cervical sample, squamous mucosa here, and a high-grade malignant neoplasm here. Very undifferentiated appearing. And so the differential would include just pure undifferentiated carcinoma, as well as poorly differentiated squamous carcinoma and neuroendocrine carcinoma. Now this lesion has a little bit more cytoplasm. The nuclei also are quite large in this lesion as well, with this expressed neuroendocrine markers. And I don't believe this was associated with other types of tumor. Here we see a little bit more of this neuroendocrine pattern, if you will, a little bit of insular and trabecular type growth. Here's another example of cervix, and I believe this is one where we have a mixture of types. So we'll look here at the small cell variant first here. As you can see, a very abundant central necrosis, a lot of small type cells, high grade, appearance. Looks like small cell carcinoma. But don't just stop with that. Make sure you look at the other areas surrounding. As this case, I believe. Here we go. Yes, this case did have some areas of at least adenocarcinoma in situ associated with it, and I believe there may have been invasive adenocarcinoma as well. So that's also helpful, of course, in determining and assigning this as a HPV-related lesion. So yeah, here's more of that adenocarcinoma with apical mitotic figures and atypia, and a little bit of the feature suggesting invasion, inflammation, and sort of a desmoplastic stroma. So I'll just pause here before I go further and answer this question for Dr. Lin. Distinguishing neuroendocrine tumor of the pancreas from solid pseudopapillary neoplasm. That's a good question because both lesions can have neuroendocrine markers. The solid pseudopapillary tumors, of course, typically present in a different age group than neuroendocrine tumors. Solid pseudopapillary tumor is very much a tumor of mid-adulthood, 25 to 40 and so forth, whereas neuroendocrine tumors are usually 45 to 65 age group. The other feature that we use most typically is the presence of beta-catenin, and we use that marker fairly consistently whenever we're thinking about solid pseudopapillary tumor. The growth pattern is somewhat different, but in a small biopsy, it can be a little bit different. But I think those two stains would be useful, and those two features would be the major features. All right, now this is a sort of a problematic lesion. This is right at the edge of the cervix and deeply invading the myometrium. So here we have endocervix here, and it looks like we have some in situ or at least surface involvement of these glands here. Looking at these cells, we might say, well, is this an adenocarcinoma? It's kind of making some sort of glandular elements. But it's got a lot of these sort of almost pseudo-rosette type structures as well. And it maybe has a glandular differentiation pattern in some areas, but in other areas of the tumor, it looks much more neuroendocrine-like, as you can see here, more trabecular endocrine type of growth pattern, small nests and so forth without a typical glandular pattern. So this again may be a mixed neuroendocrine and non-neuroendocrine type of carcinoma in the cervix, or it may all be a neuroendocrine tumor with a pseudoglandular pattern differentiation, because as we see in this more deeply invasive component, this has a kind of neuroendocrine architecture here that sometimes is sort of glandular appearing, and then when we come down even deeper, very often these solid nests here again have these small gland-like spaces in the tumor. So I think this is best regarded as a neuroendocrine tumor, but the pseudoglandular patterns or the presence of true glandular differentiation can occasionally be seen in this location as well. And of course, because this looks like it's involving the myometrium proper, it could easily be mistaken for an endometrial type neuroendocrine tumor as well. Okay, well, I think we hit the 1 hour point here and ran out of slides at the appropriate time. So I'll take any questions at this point on any of these cases or the issues that they have brought up.
Thank you, Professor. Neuroendocrine tumor look like very other tumor in the organ. So it's difficult to diagnose if on biopsy. I don't see
that
I don't
TTF1 stain. Or I think the differential always.
I'm sorry, I don't hear you. I also don't hear.
Oh, okay.
Dominic is fail or I don't hear from you. Thank you, Professor. Bye.